Such a pleasure to be here with all of you. So many old friends, new people to meet, and it's just a real privilege to have the opportunity to speak today. So, let's see. Just a couple disclosures. I'm co-editor of the book Symptomatic, and just to say there are 2 copies of that book on the raffle, so just you know what to do. And I serve as the chair of the Medical and Scientific Board for the Ehlers-Danlos Society. Now, there are many, many neurologic issues experienced by people with EDS and HSD, and too many to discuss in a 20-minute talk today. So these include things like headaches. And I've heard Dr. Henderson give a talk just about headaches in the Ehlers-Danlos syndromes and hypermobility spectrum disorder. I believe he listed 13 different types of headaches. So there's a lot to unravel just there. There's nerve pain or neuropathic pain from nerve compression. The autonomic dysfunction that we see in POTS and gastrointestinal dysmotility, temperature dysregulation, and sleep dysregulation, small fiber neuropathy, the dystonias and other movement disorders, craniocervical instability and atlantoaxial instability, that's instability between C1 and C2, Chiari malformations, tethered cord, and cerebrospinal fluid leaks. So many, many different neurologic issues. Could I have the next slide, please? So just because we are limited in time, I'm going to narrow it down, focus down on 4 specific areas: craniocervical instability, atlantoaxial instability, Chiari malformation, and tethered cord. So the Chiari malformation actually sits at the intersection between craniocervical instability and tethered cord when we think about the symptoms that emerge from these conditions. So they are not mutually exclusive by any means. And we can also see the symptoms that are associated with CSF leak overlap considerably with craniocervical instability, C1 instability, tethered cord, and a Chiari malformation. So starting to try to understand what are the symptoms that would lead you to evaluate for each of these specific complications of EDS and HSD is what I'm going to try to address today. And we're going to start with something we call the cervicomedullary syndrome, which is the constellation of signs and symptoms that make us think about the possibility of C1-2 instability or craniocervical instability and Chiari malformation. So there are 3 aspects to the cervicomedullary syndrome. There's the idea of pain. And that pain may be a headache, may manifest as suboccipital pain, in other words, pain just below the occiput at the back of the head where the head joins up with the neck, or neck pain itself. There are symptoms that are due to compression of the brainstem, and these include altered vision, double vision, nystagmus or movement of the eyes, decreased hearing and dizziness, imbalance, problems with choking or difficulty with speaking, difficulty with swallowing, problems with the autonomic nervous system, and disordered sleep. And then the third element of the cervicomedullary syndrome is something we call the symptoms of myelopathy, symptoms of pathology involving the muscles. And this will manifest as weakness. Sometimes people describe themselves as being clumsy, having spasticity. Paresthesia, that's numbness or tingling, feeling kind of odd sensations on the skin. Sometimes people describe a feeling like there's water on their skin or pins and needles type sensation. Dysesthesia means that there's a lack of sensation or altered sensation to pinprick or light touch. We see changes in gait and symptoms related to the urinary system, urinary urgency or urinary frequency. So when we're starting to think about whether there might be instability between the skull and the upper part of the cervical spine, this is what we call craniocervical instability, we know now that if you do MRIs in the upright position, you're more likely to be able to detect the craniocervical instability and also more likely to be able to detect a Chiari malformation. So when we're looking for the craniocervical instability, we do an upright MRI and we look at these three metrics: the clivo-axial angle, the Grab-Oakes measurement, and the horizontal Harris measurement. And I'm going to show you what those look like on the MRIs in just a minute. But in the upright MRI machine, we ask the patient they're seated, so you're not lying down in that big donut, but you're seated and the magnets are on either side of the head like this. And then the patient will put their chin down this way and look up at the ceiling this way and look straight forward. So we do the measurements in neutral, flexion, and extension. So this slide illustrates the clivo-axial angle. The clivus is this triangular shaped bone at the base of the skull, and the axis is, actually that should be, so axis is C1, and we've got an angle between the base of the axis and the clivus, which is called the clivo-axial angle. And that angle is usually somewhere between 145 and 160 degrees. But if it is less than 135 degrees, that suggests craniocervical instability. So you can see in the upper picture on this slide, in this patient, in neutral, the patient the measurement is 165 degrees. In flexion, it's 155 degrees. And in extension, it's 175 degrees. So all of those measurements are pretty much fine. This is a person in whom we would not suspect craniocervical instability. But in figure B, you can see that clivo-axial angle is 124 degrees. So that is a very low clivo-axial angle, and that is one where we would be concerned about the possibility of craniocervical instability. Okay, now the Grab-Oakes measurement is a measurement that we take from the tip of that clivus. So that's that triangular shaped bone that I was pointing out before for the clivo-axial angle. The basion is the tip of the clivus, and we draw a line from the basion to the very bottom of C2. And then from that line, we draw a horizontal line to the dura. And if that measurement is more than 9 millimeters, then that is suggestive of craniocervical instability. So in this case here, you can see it's 8.4 millimeters. That's within what we expect to be the more or less normal range. And then finally, we have this horizontal Harris measurement, which again, we're using the basion as a landmark. But we start off with a line along the posterior edge of the axis and draw a line from that straight up line along the posterior axial line to the basion. and measure that. And that, in this case, is 13 millimeters. But we look at both the absolute measurement, which if it's more than 12, is suggestive of craniocervical instability, or if there's a change of more than 2 millimeters between flexion and extension, that is also suggestive of craniocervical instability, because it means there's more movement in between the skull and the base and the top of the spine, the C1. So either of those metrics may be indicative of craniocervical instability, a measurement of more than 12 with the horizontal Harris, or a change of more than 2 between flexion and extension. And this is illustrated here. In figure A, you see a horizontal Harris measurement of 10 millimeters. In figure B, a horizontal Harris measurement of 3 millimeters. That's a change of 7 millimeters, so that's much more than 2 and suggestive of craniocervical instability. And then we also see on figure C the cerebellar tonsils. That yellow arrow is showing the cerebellum, which is the part of the brain that sits at the back of the skull. Looks a little like a fist, like this. And this part of the fist is what we call the cerebellar tonsils. Those usually sit well above the opening that's at the base of the skull, which we call the foramen magnum. And if those cerebellar tonsils fall down into that opening at the base of the skull, that is either low-lying cerebellar tonsils if they're sitting right at the opening, or if it goes right through, it becomes a Chiari malformation. So the atlantoaxial instability is instability between C1 and C2. And the symptoms of atlantoaxial instability are pain at the base of the skull. Sometimes people will describe intermittent burning limb pain. They may have brain fog and difficulty with memories, visual changes, auditory changes, problems with hearing or ringing in the ears. They may have fainting or near fainting, syncope or pre-syncope, nausea, and fatigue. And when we look at people on exam, if they have atlantoaxial instability, they may have increased reflexes. So when we test their reflexes, they're very jumpy. They may have diffuse loss of sensation, both to pinprick and to light touch. If you push over the area at the very top of the neck, there's tenderness there over C1-2, and they have impaired coordination. So we do this finger to nose testing where we ask people to touch their nose and then our finger. They're going back and forth like this, and they may have difficulty finding the finger and sometimes even finding their own nose. And then this dysdiadochokinesis is a test that we do where you do back and forth like this. It's just a coordination test, basically. And if that's difficult, we call it dysdiadochokinesis. Now, to look at instability between C1 and C2, we do a CT scan. The MRI is really good for looking at soft tissue landmarks, and it can show us the bony landmarks as well. But CT scans are even better for looking at the bony landmarks. And what we can do with the CT scan, looking specifically at C1 and C2, is we have people turn their head from left to right and see if there's a loss of the contact between C1 and C2 with rotation. The craniocervical joint is the one where you're moving your head forward and back for the most part, and C1 and C2 is where your rotation is from left to right. So if you have a normal overlap between the C1 ring and C2, then there is no craniocervical instability. But if C1 actually moves right off of C2, which is what's happening in the second figure on this slide, that is indicative of instability. There's too much movement between C1 and C2. Now I'm going to put a little plug in for Leslie Russick's presentation. She's going to be talking about physical therapy and the management of upper cervical instability. And I really have to recommend this paper, which was published in the early part of 2023, which is an expert consensus on treatment of craniocervical instability. And the first line of defense is physical therapy management. So this paper is freely available at Frontiers in Medicine, and I think anybody who's dealing with issues related to craniocervical instability or atlantoaxial instability is well served by taking a look at it. Now, as I mentioned a little earlier, the Chiari malformation is a phenomenon that we see when the cerebellar tonsils protrude through the foramen magnum, and if they extend more than 5 millimeters below the foramen magnum, we call it a Chiari malformation. If they're at the, just right at the foramen magnum or just a little bit below, we call them low-lying cerebellar tonsils. And the clinical presentation for a Chiari malformation, people describe what they call a tussive headache, which is a headache that is worse when you cough, or it may also be exacerbated by a Valsalva maneuver, anything that increases the pressure in the chest or the abdomen. People also describe dizziness, and they have difficulty with balance or cerebellar dysfunction. There may be problems with the lower cranial nerves and difficulty with gait. Now, a complex Chiari is a Chiari malformation, but also with evidence of what we call basilar invagination, which can be caused by either a low clival-axial angle or the retroflexed odontoid. The odontoid is a funny little bone on C2 that sticks up like a finger, and if it's pushing back against the cerebellum and the upper cervical spine, that's what we call a retroflexed odontoid, and it can indent into that place where the cerebellum joins up with the upper cervical spine. So we may have basilar invagination with the Chiari, or there can also be craniocervical instability after a Chiari malformation, and the treatment for that is a suboccipital decompression and cervical fusion and stabilization. And the last item I'd like to just discuss today is the issue of a tethered cord. Tethered cord is caused by compression and pressure on the cauda equina, which is the base of the spine, the very bottom of the spine. We're moving from all the way up at the top to all the way up down at the bottom now, by a band of connective tissue, which is called the filum terminale. And this affects the nerves that go to the bladder, the bowel, the perineum, and the legs. And patients report urinary urgency and frequency, difficulty starting the urinary stream. They may have severe constipation and in some cases bowel incontinence. Often they'll describe a real preference for sitting with their legs curled up underneath them or sleeping in a fetal position. They have low back pain, a description of heaviness in their legs. And the back pain and leg heaviness seems to be worse on walking up a hill or walking up a flight of stairs. And often they'll have a history of toe walking as youngsters when they're just starting to walk. The tethered cord in children is often manifest by a low-lying conus, which is the base of the spine. It usually sits around L1, L2, but with the tether, it pulls that conus down. It can be as low as L3, L4, or even L4, L5. What happens as people get older, as they're growing, the phylum stretches out, the conus goes back up, and so often we can have the signs and symptoms of a tethered cord, but without being able to see it on the MRI. And so that's what we call an occult tethered cord. It's there, but we can't see it. So we do an MRI to assess the position of the conus, but also can use a test called urodynamic studies to look for evidence of a neurogenic bladder. That means that the nerves that go to the bladder are being compressed, and that would be evidence that there might be a tethered cord. I'm not going to go into the details about the surgical management for a tethered cord. The references for a lot of what I've talked about are here, and I thank you very much for your attention.